Here at ASH in San Diego, we present a poster on the so-called iPATH study. iPATH stands for Irish Personalised Approach to treat patients with Hemophilia. The idea here is that Irish patients representing a quite close community and cohort of patients because of the island situation, also because they are working all together jointly, led by the Royal College of Surgeons and the Trinity College in Dublin, who are guiding all the hemophilia centres in Ireland for a common treatment practice. That is probably unique in the world, but helps us to perform a study like iPATH, because the idea here is to look into what happens if you personalize treatment approaches for hemophilic patients. Personalization means that you adjust the dose of treatment according to the needs of each individual patient. And the tool that is helping to do so is called MyPKFit. That is a form of telemedicine where there is a computer-based program available where data from the patients are put in, like simple data like body weight, age, severity of their hemophilic disorder, meaning factor 8, baseline factor 8 levels, but also their treatment circumstances, their treatment and living behaviors to optimize a therapy for them. That's done by the physician, so they prescribe within the label indication, in the case of the study, Advate, and then they monitor the patient with this computer-based app, because the patient has a regular feedback from an app that he's using on his smartphone that gives him information about his actual factor level. The way how this is done is that you take 2 blood draws from a patient to do a pharmacokinetic. That sounds unusual, but that's doable because the factor 8 levels taken in 2 subsequent blood draws within the regular decay of factor 8, be it 3 and 24 hours after application of factor 8, measuring the factor 8 level by a standard factor 8 assay, and then by a so-called population pharmacokinetic model, you adjust the pharmacokinetic curve for this specific individual patient. And that's translated into when the patient sees on his smartphone a symbol as a battery showing if it's fully charged, or if it's half charged, or if it's in the red zone where he requires an additional dose of factor 8. So what the iPATH study so far did is they collected of a cohort of more than 120 hemophilia A patients, their demographics, their treatment regimes, and looked into first parameters related to let's say the bioavailability and the pharmacokinetics of factor 8. So the study, for example, could demonstrate something that had been assumed before based on available data, but now in a systematic way, that von Willebrand factor levels influence factor 8 levels. We know von Willebrand factor is the chaperone protein that stabilizes factor 8 in the circulation. And here it could be shown that von Willebrand factor levels correlate with circulatory half-life. Same for age. The older the patient, the longer the half-life was. And the most striking result of the iPATH study was that there was a correlation found between half-life and prescribed dosages. So the shorter the half-life, the higher is the dose the patients would have been prescribed. That's also something which would have been assumed before, but now this was firstly shown systematically in a controlled study situation. And then to come back to your question about the biomarkers, the iPATH study does not stop with that. All the patients in the study are monitored for their specific phenotype and also for their genotype. So we are acquiring phenotypic and genomic data from the patients. Phenotypic means that biomarkers are measured in the patients that are looking to bone health, joint health, inflammatory status, antibody development. The goal here is at the end to answer some key biological questions that are yet unsolved for hemophilia A patients. One question is, why do some patients the same therapeutic prophylactic regime bleed and still show some breakthrough bleeds and others do not? Why do some develop joint disease only having 2 or 3 bleeds and others never do? So this is unknown. It must have a reason in their other biological factors that we are currently not understanding. And the aim of the study is to identify those factors, also going back to genomic information. So the genome is sequenced of all the patients, and then there will be systematically looked into what determines a patient having low joint bleed towards a patient having high frequency of joint bleeds. And then the ultimate question will also be, why do some patients develop inhibitory antibodies, and why do some patients not develop inhibitory antibodies against factor VIII? And finally, the PK question, why some having short half-lives, others having long half-lives. For this we have initial answers with the von Willebrand factor, as I just explained before, but I think there is more to come. The study will last for 4 years, and we are now after 18 months, so there's a lot of work ahead of us. The first time that things that had been known for a while are systematically investigated, relating to the influence factors of pharmacokinetics. It's also the first time that in a systematic way population pharmacokinetics is used to support getting data of such patients. The next steps are the additional biochemical and genetic work that will be done in the next 2.5 years, and then the expansion beyond Ireland. And then we probably could rename iPATH without changing the acronym, but I would then not stand for Irish but for international.